Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran. And once again, I'm so happy to have the chance to share this educational platform with all of you from around the world. And as always, as I say in my Hot Seat sessions, I'm so grateful to have amazing educators and friends that accepted the invitation and are joining us and sharing their knowledge, sharing their expertise and skills with all of us and help everybody around the world focus on implant dentistry, becoming better and better and better by knowing every details in the field of perio and implant. And today I have another great friend, a very skilled surgeon, Dr. Olivier Carcuac is here with me. Hello, Olivier, and welcome to Hot Seat, my friend.
Hi. Hi, Omid. Thank you. Thank you so much for having me here. Thank you.
It's our pleasure. It's our pleasure to have you. And, you know, in season 3, everybody knows that we decided to open the topics by going through the cases also to make it more understandable and more practical for everybody that heard about the topics over the past 2 seasons. So I think it will be more exciting in the learning curve of all the audience to see how skilled surgeons works and how ideas come to their mind. And today the topic that Olivier are going to cover for us is about the recessions in the lower anterior mandible, which is, I believe, as a periodontist, is one of the challenging areas, not only in field of perio, but also in reconstructions, in implant dentistry, in everything, because the tissues, the bone there is very delicate, is very thin, and we should manage everything properly to achieve the maximum aesthetic outcome possible. And I'm super excited also to tell you that recently Olivier published a new technique. It's called modified free gingival graft on IJPRD Ron Niven's journal in 2021. And I think this is the first platform that officially we can say that we will talk about it. I hope it is like that. And before we start, I would like to have a very short CV of Olivier for all of you, and then I won't make you all waiting much longer, and we will go through the presentation, and at the end, we will have a discussion on the topic. Dr. Olivier is a board-certified periodontist who has been working at My Dental Clinic in Dubai, UAE, since 2015. He is also research associate at the Department of Periodontology. The Sahlgrenska Academy at the University of Gothenburg, Sweden, graduated for DDS degree in 1998 and received his certificate as a specialist in periodontics in 2015 from University of Gothenburg in Sweden. Currently, he is a member of the editorial board of Clinical Oral Implant Research and serves as a referee in several other journals. He is also a speaker in many international congresses and has written several scientific publications within the field of dental implants and periodontology. His research includes peri-implant biological complications, their etiopathogenesis and treatment in both preclinical and clinical settings. He also has a passion for aesthetic periodontal procedures as well as aesthetic implant dentistry. Once again, Olivier, I'm so happy to have you on Hot Seat, and really looking forward for your beautiful presentation, my friend.
Thank you so much, Omid. Once again, I'm very pleased that you asked me to join your tremendous session there. I just want to congratulate you for the amazing work that you have done by gathering all these speakers around the world. And it has been a pleasure to listen to you for the 2 first seasons. And I will really engage me in this session for the best of this discussion there. I will just share my screen with you. So let's see here. And as you said, you cover lots of different topics with the previous speakers. So I have had some time to think about what could be interesting for the audience to listen. And you said I've been periodontist since now more than 12 years, and I am on a daily basis facing situations where patients are coming to me for addressing Recession defects, very, very common. And I am still struggling a lot when it comes for recession defects in the lower mandible, in the lower incisor. And that's the reason why I would like to share with you how I tackle this kind of situation. What's my plan when I see a patient? I am planning and preparing my therapy with them. So we will focus on recession defects at lower incisor with you for this coming hour. So this is the kind of situation which is pretty common. And of course, mucogingival therapy, they have been very well described in the literature. There is many different techniques, and it's actually quite a hot topic for in many different congresses and symposium. But I am still surprised, to be very honest with you, that very often studies are focusing on, or there is very few studies focusing on this area of the jaw. Most of the studies are focusing on the upper part, obviously for aesthetical reason. Patients are motivated to address this situation because of aesthetics. But I mean, there is different studies, large studies, and a very recent one published by Romandini and the Madrid group of Mario Sanz, based on a huge database from the NHS in US, about more than 10,000 subjects, showing that actually the most prevalent teeth for developing recessions are teeth located in the lower mandible. And very actually few cases, or much lower numbers, are addressed on the upper jaw. So this discrepancy between what we see clinically, and most of our patients are actually presenting defects in the lower mandible, while many studies and guidelines are given to clinicians when it comes to addressing situation mostly located in the upper arch. These studies, they have been also corroborated by other large studies by Alan Bandara for now many years back, which also showed that mandible central incisor are the most prevalent, one of the most prevalent teeth to develop recession defects. So what kind of situation, I mean, when we have a healthy situation compared with the thick situation, obviously we have lots of anatomical parameters which make the situation much more difficult to treat. And that can be this high attachment of the frenulum, or that can be this very shallow vestibule that we have, the almost frequent and permanent absence of keratinized tissue in the apical portion of the recession. And all these parameters obviously make our treatment difficult, not as predictable as in other areas of the mouth. Many different techniques have been described. Free gingival graft may be the first of them, where a recipient site is prepared receiving a free gingival graft and very specific in the mandible area, because for aesthetical reason, the outcome is not very pleasant. Yeah, but this is one of the first techniques. Then the techniques have evolved, and we have applied what we call flap surgery or flap approaches, where we have in thin phenotype, we adding a connective tissue graft to a coronally advanced flap, where the tissue placed apically to the recession or moved forward in a coronal position. We have also a tunnel technique, which has been described, where we create an envelope around these teeth, and we place a connective tissue graft, which will make the tissue thicker, and we suturing technique, we can even advance this tunnel flap more coronally. We have also in certain conditions the double papillar flap, which has been described, not so frequent because the indication for that are more limited, but definitely in some cases a very well described technique, or the lately described technique by Scullern, the laterally closed tunnel, where it's minimally invasive tunnel when we try to approach the edges of these recession defects to cover the defect. So once again, and I just want to just show you here, you will see on the screen some QR code. If you take your phone and shoot this code, you will have access to the articles, yeah, that I show in this presentation. Different reviews have been done showing and trying to evaluate the outcome of such treatments, different flap surgery or tunnel or free gingival graft, disregarding the region of treatment. So it can be in the upper, most of the studies are in the upper front. And what we can see is that if we now look at the mean complete coverage achieved, we have pretty good results when it comes to flap surgeries or tunnel technique, while the results achieved with the free gingival graft are much less, yeah, about 48% of success rate when it comes to the full coverage. So when we come back to this area here, the lower incisor, and we try to see and to see which parameter have definitely an impact on our decision making when it comes to choose the right technique to address such situation. And of course, we have to take into consideration not only the topography of the recession, the extent of the recession, the depth and the width of the recession, but also the phenotype of the tissue, the depth of the vestibulum, the root eminence, among many other factors. And we have, for this specific situation, mostly three possible techniques to be used: either the CAF, the coronary advance flap, the tunnel, or the laterally closed tunnel, or the free gingival graft. And we face in each parameter different situation. Phenotype, when it comes to the coronary advance flap, either thin or thick phenotype, this technique can be indicated. Yeah, if the phenotype is too thin, we will need to add a connective tissue graft. If the vestibulum is short, it will be very difficult to move this tissue apically in a more coronal position. So definitely a short vestibulum is definitely a limitation to apply the coronary advance flap. The same when it comes to the root prominence of these teeth, it can be very difficult to prepare correctly a recipient site when we have very prominent profile. The same for the tunnel technique. It's very well indicated when we have mainly a thick phenotype, because the tissue are very difficult to manipulate when we do it blindly to create this envelope around the teeth. Also, the vestibulum depth can be a limitation with this technique because, again, we move this tissue more coronally. And the root prominence, definitely in this technique, is very, very, very challenging because it's very difficult to follow the architecture of the bone when creating this envelope around the teeth. So that's the reason why in this area, very, very often we have the free gingival graft, which is very well indicated because disregarding this aforementioned parameter, this technique is always feasible, disregarding the phenotype, the depth of the vestibulum, or the prominence of the roots. So if we take a look on another publication where different areas have been treated by a coronary advance flap, we can see that we are very successful, and you can see on this table here, the median root coverage. It's very high for teeth in the upper arch, less favorable in the lower arch, and the less results, or the less favorable results, is definitely for the sextant 5, which is the lower incisor. And once again, one of the main reasons explained by the authors is the unfavorable anatomic condition that we just talked about. So definitely, this is a limitation of using a coronary advance flap in this area. It can be done, but in terms of predictability of the outcome and in terms of success rate, when it comes to the complete root coverage, we have difficulty to reach this good number. So for those who are now listening in the audience who are not really familiar with this, what consists exactly this free gingival in? So I will just very rapidly cover the technique itself, yeah, and how this technique, we will see later, can be modified to achieve better results. So of course, the root surface which has been contaminated needs to be clean in order to achieve or try to achieve a good healing and attachment of the new tissue placed over the exposed root. When done, we will now prepare our recipient site. The recipient site is prepared by placing horizontal incision bilaterally of the recession at the level of the cemento-enamel junction, because that's the level where we expect our coverage. Okay. Then we add to this horizontal incision two vertical divergent incision, which will go through the mucosa, and we create apically an horizontal incision. This area, which has been now limited, will be desepithelialized. And we have created a kind of wound, that's our recipient site, which will receive the free gingival graft. So just to show you very, very quickly how it works, we create an area around the recession defects, and you can see here that there is almost no depth of vestibulum here. There is no keratinous tissue apical to the recession. All this tissue is fully mobile. We create a recipient site at the level of the CAJ, and we desepithelize this area, creating our recipient site. Very important in this technique to create a recipient site which is not mobile, but very close to the bone, so that the free gingival that we will place on this recipient site will not move with the tissue. We then create a template because we want a free gingival graft to be perfectly adjusted, adapted to the area. This template is to the palate, which is frequently the area of harvesting, to create exactly the size of the graft that we need. This graft will be covered by epithelium. We delimit the graft, and progressively with scalpel, with blade, we are just removing a graft which is about 1.5 to 2 millimeter in thickness. And when harvested, we will place this graft exactly where the recipient site has been prepared, covering the root surface and the surrounding tissue. This graft needs to be perfectly adapted to the recipient site. It needs to be perfectly anchored with multiple sutures. We can sometimes need to add other suture to be sure that there is no void between the graft and the recipient site. That can be horizontal, as you see on the picture, or vertical placed. So that's more or less how it looks clinically when we have prepared and placed our graft. So what's very important now, I think, is just to know exactly how we do evaluate the surgical root coverage procedure, the outcome of this technique, because the patient very often is coming to us with sensitivity, discomfort with this area, and the purpose of the treatment, the main essence of this treatment, is actually to cover the exposed root, okay? So the main primary outcome, very well described, very often described in the literature, is definitely the complete root coverage, disregarding the technique which has been used. Then the secondary outcome can be how much we can reduce these recession defects, or how much gain we obtain, how much keratin tissue we have created after this technique. If the aesthetical outcome is satisfying, if there is no more root sensitivity, and if the patient have different pain or discomfort, what we call the patient-centered outcomes. So why this is so important? It's just because in many cases, when we have a surgery performed, we can achieve very good results, as you see on the picture here, but still, when we take into account the position of the cementoid junction, we still have a small portion of the root which is exposed, and this portion can be very sensitive still. So when this technique has been applied, and this is very often the result, that's the result that we can achieve, we have in this case covered the entire recession defect. We have also created a large width of keratinized tissue. If we take a look on the occlusal view, we have also a much thicker tissue. So question is, how successful are we with this free gingival graft? And as I showed you, according to literature, we are not as successful as for the other technique. I can show you great results. I can also show you not so great results. And very, very often, the results are very limited in terms of outcomes. Now, and that's the reason why I wanted to emphasize the expectation of the treatment. If the purpose of the treatment is to create a width of a band of keratinized tissue, definitely the failure cases that you see on the right side of the picture are not failure in this concern, because we have created a condition which is obviously more stable than initially by creating a keratinized tissue apical to the recession. But in terms of root coverage, even if we have reduced, we have not achieved our goal of therapy. So once again, if we take a look on the literature, we can see that there is different outcomes described, but most of them are very shy compared with other techniques. So once again, I mean, in this case, we have a situation where we, at the end of the surgery, are very happy. We have covered everything. We have very high papilla, so that means that anatomically, we have good condition to have a good situation at the end. But still, after healing, we still have a remaining defect. And if you compare the picture before and after, you can see that in terms of root coverage, it's very, very, very limited. So the question is always why? Why are we struggling with this outcome? Is it anatomical factors which are implicated or technique limitation? So to be very honest with you, because we have very great outcomes when it comes to flap surgery. So it's very, very easy to compare the two techniques. When we have a flap surgery, compare with the free gingival graft. And what you see here, it's only the recipient site which has been prepared around these two situations. When we have this situation, understand that the graft, the CTG, the connective tissue graft, is placed on the root surface and will be covered by the flap in the connective tissue, in the coronary advance flap. While in the free gingival graft, this graft is still exposed. It's not covered by any tissue. So that means that in terms of blood supply, because we do understand that a graft needs a good blood supply, a quick blood supply to be able to survive. We have in this condition, both conditions, some area which are, we call them vascular. We know that the blood supply will come from them, while we have some area which are avascular, but we cannot count to receiving any blood supply from them. And if we take an old study, histological study, where we see the healing after a connective tissue graft, what we can see on this histological section, you see the root, you see the bone, you see the recipient site, and you see the flap. And the connective tissue graft in yellow is placed in between. When we create a recipient site for the connective tissue graft for the coronal advance flap, we always expose the marginal portion of the bone. And why? To be able to have a very thick tissue flap in the most coronal portion of the flap. So that means that in terms of vascularization, we have lots of area which will give vascularization to our graft. This vascularization comes from the parental ligament, from the recipient site itself, and from the flap covering the graft. If we do the same kind of examination, histological section on the free gingival graft, much older section, we can see again the root, the recipient site, and in the free gingival graft, there is no bone exposed. We only have a recipient site, all right? And on this recipient site, we place the free gingival graft. So the only blood supply is coming from the recipient site. That's it. So nothing covers the graft. So we are very much depending on the quality of blood supply from the underneath recipient site. What we do know is that the free gingival graft is actually also used in many other indications when we have to increase the width of cartilaginous tissue in edentulous area. And we do exactly the same. We create a recipient site, we place our free gingival graft, which is not covered. But in this specific situation, that's what you see on the left side on your picture, you see that there is, in this case, no avascular area. The entire recipient site is vascular. And that's the big difference between the two indications of the free gingival graft. And we do know that this site, even if we have no flap covering the graft, this site, if it's all vascular, is good enough to supply good blood supply for the graft to survive. Anastomosis are created very quickly and it works perfectly. So the limitation that we have when we have free gingival graft for covering gingival recession defects, when we prepare our site, we have our recipient site, which has been designed there and prepared. We still have this avascular area. And the question, can we do something to change that, to be able to create a better recipient site? And that's the reason, that's exactly what led us, myself and my dear colleague Jan Derks, to this technique. Is that a technique? And that's not a new technique. I will show you later. That's not a new technique. But this technique has been forgotten. Yeah. And it's a great technique because you will see that we can change significantly the blood supply of the recipient site to significantly change the outcome of this treatment. So the site is prepared exactly the same way, slightly. I will show you later some modification. And the idea is to use the surrounding tissue that we have. And in this specific indication there is to use the apical portion of the recipient site to create a kind of pedicle which is flipped over the root surface. So the entire vascularization of this pedicle is perfectly preserved in the very apical portion, yeah? And that will maintain the blood supply. It's like a flap surgery, okay? We just reverse the flap here. So the vascularization is not cut in any way. And by just fixing this pedicle around the root, we transform this avascular area into now a vascular area. And we have now a full recipient site, which is fully vascular. So the big difference, and that's something that you, my colleague, when you want to address, to do this technique, you need to be prepared. Why? When you do a free gingival graft, I told you initially, you want the recipient site to be very fixed, right? And to be fixed, you need to remove all portion which is mobile from this recipient site. So you need to be very close to the bone, to the periosteum, all right? In this technique, you want to keep tissue apical to this lesion because you will just flip this tissue coronally, all right? So that means that when you desepithelize this area, you need to be careful to not remove too much thickness of this tissue, just the epithelium, all right? Just to be sure that you will be able then to use this apical portion of the recipient site to prepare a flap that you will flip over the root surface. It's flipped, it's suture, and now you see the difference. All this area is now vascular. The rest is the same story. We harvest the free gingival graft to be sure that it matches perfectly the size of our recipient site. This graft is perfectly fixed to the recipient site to have no mobility, to have no void between the graft and the recipient site. And that's a picture on your right, which is just 1 week after or 2 weeks after the surgery. And we can see that the level of the tissue is well preserved. This tissue is pinkish, which is good. That means that we have a good vascularization in our graft. And the follow-up after 6 months for this picture show that the graft has perfectly been integrated and maintained in terms of level to the CAJ of the tooth. Another example here, and we always try here, there is 2 teeth, we always try to augment the size of the recipient site just to have a better vascularization of the graft. The same story here, we use the tissue which is located apical to the recession. We prepare a pedicle flap that will flip over the roots. We place our graft, and after cicatrization, healing in 2 weeks, and in 1 year, stable situation. So the difference, and understanding correctly, we can achieve this kind of outcome also with a normal free gingival graft. But in terms of predictability, we are not here. While with modifying this approach, the recipient site preparation, in terms of predictability, we are much, much, much better. So exactly, and I'm very proud to have this article, this case series published in this International Journal of Periodontics and Restorative Dentistry, based on three cases where we prepared exactly as I showed you the recipient site, prepare flap that we flipped over the root surface, we place our graft, and this is a follow-up after 6 months. Yeah. So of course, this story doesn't end there. Yeah, we need much more data. We need much more studies. We have an ongoing RCT study where we will compare the free gingival graft compared with this modified approach based on, so it's a randomized studies. It's based on a proper amount of patient with a follow-up which is of 1 year. And I hope that I will be able to share with you some preliminary data already now. So what I face when I prepare this modify recipient site is that sometimes we have some portion of the root which is still exposed. And the question is that a problem? Clinically, is that a problem? Well, again, based on all studies, what we call the bridging phenomenon occur. That means that it's a kind of, the iceberg. If the portion of the exposure is much smaller or less compared with the portion which is covered, that's not an issue. If this exposure is placed apically, that's not an issue. The same thing, if you exposed in some area the bone, when you flip this pedicle flap, is that a problem? No, it's not a problem. The graft will still receive proper vascularization and blood supply to survive, even from the bone. Yeah? So it's not a problem. This technique is not only suitable for mandible area or lower incisor, it can be applied in other area. Just to show you another example here, where we have this situation, which could have been treated different way. Yeah, it could have been done a lateral sliding flap, but we decided to do this approach there. And the same area here, the same thing here, we prepare our recipient site in such a way that we maintain a proper thickness of tissue in the apical portion, tissue that we prepare and that we flip over the recession. Now we place over this new prepared or new recipient site, modified recipient site, the graft. The same way, it's perfectly adapted to the size of the recipient site. It's completely fixed. And after healing of 2 weeks, that's the situation. where we see a perfectly maintained level of this graft, and after 1 year, a perfect maturation of this tissue. And for this patient, no need to consider doing any coronary advance flap in this area here. So as I told you, this technique is not new. Yeah, this technique is not new. Actually, the first technique showed was from a Swedish dentist in 1926, long time ago, Dr. Norberg, who actually applied this technique. The fact that you create a flap, a pedicle here, that was for periodontal defects, where a pedicle was created and placed covered by a flap. Yeah, it was not covered by a free gingival graft, but by the flap. Yeah, so that was done for surgical treatment of periodontal defect. That technique was also described for many years back by Carl Vallo, who described this technique by using the lateral portion of the recession to move this to kind of papilla area and cover the recession defect. We found this technique much more limited because the preparation site is much more difficult, much more limited and in terms of extent. And that's the reason why we modify that to the apical portion, because it's easier to perform and we have much more tissue to move and cover the root surface. So just for you, as to keep some more suspense there, just to show you some preliminary data about our ongoing RCT studies on the modified surface. We will include 30 patients, 15 in the free gingival graft, 15 with the modified approach. That will be randomized, or it's randomized studies. The complete root coverage is our main outcome, the primary outcome, but we'll also take into consideration many other parameters as listed on the slides. And I can show you is that from a baseline perspective, we take care to have very similar defects in both groups. Yeah, there's no difference in terms of extent of the recession. They are very comparable. In terms of width of keratinized tissue, they're also very comparable. And this is a follow-up which is done for 1 year. The patient is followed 3-6 months and then 1 year. And this just from preliminary data based on 5 patients in each group, where I can already show you here that in terms of at 1 year follow-up for this first patient, we have in terms of complete root coverage, almost 4 cases out of 5 with the modified technique have a complete root coverage. In terms of reduction of the recession, we have in terms of remaining recession, that's what you can see in the first line of this table. We have still a remaining defect with approximately half of the exposure, initial exposure for the free gingival graft, whilst it's almost complete root surface coverage with the modified technique. In terms of discomfort for the patient, they are very much similar. There is no big difference, but in terms of satisfaction, obviously, because patients are consulting, most of them, or very many of them, because it's not ethical reason, but it's more for hypersensitivity. And there is a big difference there. Having more coverage achieved with the modified technique, there is less sensitivity after the procedure. So in terms also of keratinized tissue, we have better width of keratinized tissue because we have more remaining tissue. Yeah. So just to sum up a little bit our discussion today, that this modified technique that has been is issue from a reflection, yeah, of many cases, issue from kind of frustration that we had because having a free gingival graft, which is very much indicated and almost the sole technique possible in the lower incisor, we still had patients where we couldn't achieve great results unless you do a step procedure. That means that you do a free gingival graft first, you let it heal, and then you move this new tissue coronally. That's feasible, yeah. But we wanted to find technique where we could achieve in one go the same result in terms of predictability and root coverage that we usually achieve with coronal advanced flap, for instance. So this is very well indicated to achieve this modified technique to achieve a good reduction of the recession defects. You can also achieve very good increase of the keratinized tissue and a thickening of this phenotype. This modified technique gives us outcomes which are now more or less almost similar to other flap technique. Yeah, and of course, aesthetically, we still have to face this concern because the free gingival graft is still there. So in terms of texture, of shade, is different. So definitely it's not indicated to other areas which are located in the upper ear. We have way better technique to be considered. And of course, yeah, we need, and I hope that many other that will create an emulation for many of you wanted to try, and for other research center who wants to implement that in the research to have much better data on this technique. So yeah, that was it. I hope that you enjoy. Now I am fully prepared for all your comments, my dear Omid.
Thank you so much.
Thank you.
Thank you so much. First of all, if it was in person, I would like to give you a clap because it was amazing presentation and full of knowledge. I have to say, it's not a compliment.
Thank you.
And you know, I think you opened so many ideas and questions by bringing this technique back in our daily procedures. You know, first of all, I would like to have a question regarding the depth of preparation, because, for example, in cases that we want to prepare a recipient site for free gingival graft, we want to know, for example, how much width and length we want to put our graft in the area. Now that we want to bring that pedicle, like a kind of tissue from apical to the top, do you have any specific criteria regarding to measure and how many millimeters our recipient bed should be deeper to bring that pedicle up? Do you have any numbers, or is just by
well, I can explain to you how I proceed. I mean, it's very depending on the situation that you face, of course, because this flap, the height of this flap, of this pedicle, depends on how much root surface you have to cover, all right? So we do know that when we prepare and place, and that you can see now on the screen, you can see that the free gingival graft is placed, but we still have in the very apical portion still an exposed wound, right? So the apical portion, even if you prepare a recipient site which is longer or deeper than the free gingival graft, that's never an issue, okay? So I will definitely, when you are starting with this kind of procedure, try to do a recipient site which is deep enough, yeah, apically, yeah. Now, it's never a problem to augment if you now, when you start preparing your site, you see that the root surface, the length of this exposed surface is longer than what you expected, that you will need to prepare longer pedicle. You can still, you know, increase the depth of your preparation. That's never a limitation. But what guides me when I prepare this site is exactly that. It's the length of the root to be covered, because what I would like, it's always to reach the CAJ of this tooth, right? Because that's exactly my goal of therapy to when it comes to the level, the margin level of my graft, yeah.
And the thickness of that pedicle should be like only 1 millimeter, right? There is no need for making it thicker.
No need. Yeah, no need to make it thicker. Now it's very, I mean, it's not easy when you start doing it. You can do it, and I think that for me, what I prefer, it's actually doing it with microsurgical scissors,
Mhm.
because they are very, very easy to use, and you can very, very easily progress when dissecting this pedicle. One critical portion there, and that's something maybe that was not really, really clear in my presentation, is that what's very, very important, and you always need to think biological, okay, when you prepare your sites, it's this flap that you create, you want this flap, this pedicle, to preserve a proper vascularization. So that means that the coronal portion of the pedicle needs to be very wide, all right? Don't limit it to the width of your root. You need to be larger than that, yeah? Because once again, this pedicle needs to survive. So it gets some blood supply from the apical portion when you flip it, so the coronal portion of the pedicle, but it also receives lots of vascularization from the lateral area of your of the root. Yeah. So by being too shy and having a too narrow pedicle, you will restrict the blood supply of your pedicle. So that's my tips. Progress with a scissor, micro scissor, because it's very easy to do. But when you start creating this flap, extend it larger than the recession, yeah, than the root.
And I want to know, I think it can be also a good substitution for connective tissue in case of root coverage with coronally advanced flap, right?
I don't think so. I will not consider or consider it as a substitute for connective tissue graft.
You have a good tissue thickness that you can use that pedicle to cover the root. So
that's correct. But I think that the limitation there, it's more in terms of quality of this connective tissue. It's not really rich in collagen as we want it. You know, when we decide to do a connective tissue graft, to add it to a coronal advanced flap, it's just because this tissue, the phenotype is thin, right? So we want to have a collagen-rich graft placed there. And I think that the pedicle that we can create is not as good in terms of quality than the tissue that we can harvest from the palate or from the tuberosity. So I will not recommend it as a substitute for a connective tissue graft.
You know, the reason that I asked this question, because sometimes we have multiple recessions and we need large amount of connective tissue, and usually it's not available. And we prefer to put connective tissue grafts only in more critical areas. As recently, Sophia Aroka also published something like this, that we can use the connective tissue site specifically. So I was thinking that maybe in those cases, we can enhance increasing the outcomes as by means of predictability by combination of this approach, maybe if the tissue is thick enough to do that. That was the question. And also I want to know, what do you think in cases that we have implant surface dehiscences, not the peri-implantitis, but maybe the bone was thin and during the remodeling we had exposed, so we used the same approach to do the coverage?
Definitely, I completely agree with you. Yeah, definitely. Why? Just because the implant surface, again, it's an avascular area. Yeah, and we want to create a vascular recipient site. So I completely agree with you, Omid. Completely agree. And so yeah, I'm happy that more and more will be interested in that. Yeah, because we have so much to look at. Definitely, but that's a great indication.
I saw recently our mutual friend Israel Puterman also immediately started using this technique and posted a great case, and I saw you reposted. So it was amazing. It's amazing because so many people now can have this idea in mind and try to make this technique more improved.
That's correct. I think, you know, it's a mindset. If you open to that, then when you will have a case, you will think about that. So it just, if you're aware of that, and once again, it's nothing fancy. It's just biologically, you know, based. That's it. That's it.
And Olivier, one last thing that I wanted to ask you is regarding the root prominences. It's a general question, not only for this technique, but especially in those cases, because your focus was on anterior mandible, and usually the roots are prominent, the tissue is thin, we have, you know, prominences and depths there. So I want to know, do you always do the root, grinding the root surface by reducing that prominency before putting your graft, no matter if it's a modified FGG or FGG itself? And in what extent you recommend those root reduction prominences?
Okay, that's a very good question, because the tooth position is definitely a big parameter, yeah, for the outcome. And I would be very honest with you, my first thing is very rarely surgical approach in the beginning. And I really, when I face a situation when the root is definitely, or the tooth is malpositioned, is to try to convince the patient to do orthodontic treatment, to place this tooth back to the right position. Now, exactly as you said, the root prominence anyway can be quite an issue, especially in very thin phenotype. Yeah, even if the tooth is not malpositioned, it's correctly positioned, but we still have this very concave interradicular situation. And definitely when I consider, and I do odontoplasty on the root, yeah, to reduce the prominency of this root as a slight procedure. You really need to be very, very gentle with the reduction there. Why? It's just because, and I talk about the free gingival graft, yeah. If I have to do that for coronal advance flap, I'm pretty sure that my outcome will be good, yeah, with the coronal advance flap. That in terms of root coverage, I will probably don't have lots of remaining defects. The problem with the free gingival graft is that the predictability is much less, and that if you have an exposed root which has been tremendously reduced, the sensitivity of this root surface will be a problem, obviously. So the root can be, I cannot give you any numbers there. It's just, you need to have a kind of sense for that, yeah, and just to reduce that. Now, what I very, very often face and notice is that the problem is not really the prominence of the root, but it's mainly the concavity in the interradicular area, which is difficult to manage, yeah. So the only way to manage that when I have two teeth to prepare for free gingival graft is to try to not to be too deep in the preparation of this area.
And we can say that if it was possible, we can reduce that prominency to the level of the proximal bone. But in those cases that the bone is also to compromise the case in that situation, case by case or side by side. Wow.
Yeah.
Olivier, I have to say, I truly enjoyed it. You know, that was one of my favorite topics, and I was really looking forward to hear it from yourself. Was really looking forward to this day. So I really want to appreciate you for your time, for your humbleness to share it with all of us. And me personally enjoyed it to the max, and I'm pretty sure all of our audience did. And really hope to see you very, very soon, and hopefully soon in Iran, hopefully next year. So I will keep.
We are on neighbor. You know, I'm based in Dubai, so I'm very close to Iran.
Yeah, I will plan it. So thank you so much, my friend, for joining. It was really great talking with you, and hats off. I truly enjoyed it.
Thank you so much, Omid. Thank you. Thank you.
Stay safe.
You too.